Hi friends, I'm back again here, Sandeep, on Dr. Uniting page and Global Summit. And today as a host back again, so good evening from India, Namaste, Sat Sri Akal, Assalamu Alaikum. And today I've come up with a dear friend of mine here as a guest who will be talking on GBR and immediate implants in aesthetic area. And that is Dr. Angelo Cardarelli from Italy. But before I hand it over to Dr. Angelo for his webinar, I would like to talk about something about the program going on to Doctors Uniting. And we are taking, if you have something new, some new technique to discuss, you can book your webinar, and you could be from the field of medicine, pharmacy, dentistry. Dentistry, we are full for top 100 doctors, but you can go in for medicine, pharmacy, philosophy, optometry, and chiropractic. But you can also book in your webinars for if you have something new. And as you can see here on my right, here, you check in and you take a scan and you can nominate yourself. And on this side, like here, you scan it and you can book your webinars. So I'm expecting, and to all my viewers, that those who are willing to join us, you are welcome. Nominate yourself and you look into that. And this process is going on, and we have many interactive sessions which has been done today, and this is the last one. So I would like to introduce you, Dr. Angelo Cardarelli, and I have few words about him. His credentials. Dr. Angelo Cardarelli is an Italian oral surgeon. He graduated from Aquila University and he specialized in oral surgery in Rome, Spenza University. He focuses on surgical treatment of impacted teeth using piezosurgery device and atrophic jaws rehabilitation using a reduced number of implants. He has done many courses and lectures around the world about those topics. He worked in his clinic, Clinica Cardarelli, in south of Italy with his brother and father, and also in Milan at San Raffaele Hospital as scientific advisor, and he is an adjunct professor at Vita Salute University in Milan. So I hand it over to Dr. Angelo Cardarelli without any delay. Dr. Angelo.
Thank you very much, Dr. Singh, and thank you for your great introduction. And I would like to thank the Global Summit for having me today again, and Dr. Chiano Shar. So, good evening from Italy, and I'm very glad to share my knowledge today, talking about an interesting topic about the treatment of aesthetic area using the immediate implants procedure and the GBR procedure, a very challenging procedure. As we know, in order to place the implants, we need to follow and we need to have some requirements in a dental site about local factors and systemic factors. We need to have a sufficient bone thickness, at least 5 millimeters, a good intermaxillary relationship, a sufficient thickness and quality of soft tissue around our implants. Because the soft tissue is the management of soft tissue is very important in order to prevent the mucositis and the perimplantitis. And obviously, we need to have the preservation of the cortical walls according to the bone defect after the extraction. This is the ideal condition in order to place the implant in the aesthetic area. We need to follow the distance between the implant and the natural tooth, as you can see from this image. We need to have this distance. And also we need to respect, and as I will show later, to fill the gap between the implant and the buccal bone with heterolog bone in order to maintain the bone volume. This is the ideal condition that we need to have in the treatment of the aesthetic zone using immediate implants and GBR procedure. This is the ideal clinical condition. For example, during the extraction of the central incisor, as you can see from this case, I need absolutely, in this case, to have a good management of the soft tissue in order to obtain this result in terms of the aesthetic and in terms of the function. This is our final result, following the correct implant placement in the aesthetic area. And have a look at this CBCT reconstruction in order to understand better the correct protocol that I need to follow in this procedure. Have a look at the situation at the beginning. This is the initial situation before the extraction. Have a look at the direction of this root, of this central incisor. But according to the protocol, after the tooth extraction, I need to change this direction in order to preserve the buccal bone with a palatal approach, following the palatal bone side, exactly like this, because I need to have more than 2 or 3 millimeters in the back side, exactly like this, in order to prevent the mucositis perimplantitis around this implant. So this is the correct protocol in the aesthetic area. I need to change the direction following the palatal bone side, preserving the buccal bone, because as we know, after tooth extraction, we will have in the first 6 months, we will have an important bone resorption, especially in the buccal side, with different speed and with different direction, with horizontal and vertical direction, with different speed and different direction again. And in order to obtain a good soft tissue shape, a good blood supply, a good osseointegration around our implants, we need to follow this condition. We need to have at least 3 millimeters between the implants and 1.5 millimeters between the implant and the natural tooth in order to obtain a good vascularization and in order to preserve the soft tissue shape, in order to obtain the papilla shape around the implants. And also, as I said before, we need to have also the systemic factors in order to place this implant. So I need to stop the smoke, for example, 15 days before the surgery until 30 days later, in order to increase the blood supply, in order to increase a good vascularization around the bone and the soft tissue. And obviously, we need to control the systemic disease and the periodontal disease before our treatment. Don't forget this aspect. And after tooth extraction, we can have 3 different sockets shape as you can see from this image, the first one, this is a favorable situation. In fact, as we know, we have an intact socket in terms of the soft tissue and the bone tissue. The second type, in which we have a bone defect dehiscence, as you can see, but we have an intact soft tissue area until to the last clinical condition, very challenging case. In fact, in this situation, we have both dehiscence, in the both side dehiscence, on the soft tissue and on the bone. And have a look at this publication. In order to understand better the importance of the buccal bone in the treatment of the aesthetic area, have a look at this image. If we have a thin tissue in the buccal side after the extraction, 8 weeks later, we will have a completely bone resorption in the buccal side, exactly like this. Instead, if we have a thick tissue, more than 2 millimeters, for example, after 8 weeks, we will have a little bit of bone resorption, but we have a preservation of the buccal bone in this case. And again, the importance of the thin tissue in the buccal side. If we have less than 1.5 millimeters in the buccal side, we will have an important bone resorption, as you can see from this histological result. Instead, if we have a thick buccal bone, more than 1.5 millimeters, we will have a bone preservation in the buccal side. And according to this publication, in 86% of the patients, we have less than 1 millimeter in terms of the thickness in the buccal bone side. And in 48% of the patients, we have less than 0.5 millimeter in the buccal side. And this is the healing development after tooth extraction in intact socket 4 months later, from the beginning at the time of the extraction until to the healing of this intact socket. So we have the self-bone regeneration 2 days, 1 week later, 3 weeks later, until to 4 months later, with a complete bone regeneration, with the stabilization of the coagulum, with a degranulation by the platelets during this healing. And another thing very important is the quality and the quantity of the soft tissue at the beginning before the extraction, because according to this publication, the initial thickness of the soft tissue can influence the crestal bone resorption. In fact, according to this study, if we have a thin tissue less than 2 millimeters, 1 year later, we will have an important bone resorption in the buccal side. Instead, if we have a thick tissue more than 2 millimeters in terms of the thickness bone in the buccal side, 1 year later, we will have a little bit bone resorption. And for this reason, as you can see from this image, when I need to increase the soft tissue, I can use the connective tissue from the palate exactly like this, in order to increase the aesthetic result, in order to increase the volume, in order to protect this area by the mucositis and periimplantitis, and in order to maintain and to increase the volume around this implant. So also for the aesthetic reason. This is the connective tissue graft harvested from the palate. And during the treatment of the aesthetic area, which are the contraindications? For example, the buccal bone fenestration is not a contraindication because it's possible to use the resorbable membrane between the implant surface and the soft tissue in order to maintain the volume and in order to maintain the heterolog bond. The thin tissue phenotype is not contraindication because, as I said before, we can increase this volume using the connective graft from the palate. And also the acute infection is not the contraindication because it's possible to change the acute and chronic infection using the antibiotics therapy 3, 4, 5 days before the surgery in case of acute infection. So the acute infection is absolutely not contraindication because we can change this acute and chronic infection using the antibiotics therapy. And have a look this clinical video in order to understand better this treatment in the aesthetic area. This is the situation at the beginning, so I can't keep this dental element, so I decided to remove this lateral incisor, but it's very important to see and to understand better this clinical situation by the X-ray pre-op, by the CBCT scan. Have a look this inclination, but we have a sufficient thickness bone. But as I said before, during the immediate implant placement, I need to change this direction following the palatal bone side. So, with a traumatic approach, I can remove this residual root with granuloma infection. And for example, this is the occlusal view. In this case, I used the provisional crown to guide the drills during the implant placement, following always the palatal bone side. And obviously, I need to use the pin in order to check the correct implant placement. And only after that, I can go ahead with the next drills. Obviously, I need to under-prepare the implant side because I need to increase the primary stability because I will make the immediate restoration. The occlusal view. The next drill, according to the protocol of this implant. And after that, I can place the implant 3.75 of diameter and 13 of length with high primary stability, more than 35 Newton. And after that, I can fill the gap between the implant and the soft tissue and the bone, with the heterolog bone. And after that, I can screw this crown. Screwed provisional crown without occlusal loading, obviously, during the first 3 months, during the osseointegration. The X-ray post-op, but it's very important to see the CBCT. So according to the protocol, I placed this implant following the palatal bone side, preserving the buccal bone, and I filled this gap with the heterolog bone. The heterolog bone, in this case, I used the bovine bone, is not involved in the osseointegration, but is very important in order to maintain the volume for the aesthetic reason, especially in the aesthetic side. Sorry. The situation 3 weeks later, and after 3 months, this is the healing, a good volume, a good soft tissue shape. After that, I can take the impression using, in my practice, I use actually always the intraoral scan. This is the occlusal view, and as you can see, we have a very good result in terms of the osseointegration and the soft tissue volume. The final crown made in ceramic, screwed crown. The details of this crown and the final result with a good aesthetic and a good soft tissue shape. But in some cases, we have not the possibility, according to the residual cavity after the extraction, we have not the possibility to place at the same time the implant exactly. As you can see, in this case, this is the situation at the beginning, the CBCT reconstruction, we have not bone in the buccal side. So in this case, I decide to remove with a traumatic approach this root. And as you can see, we have not bone in the buccal side, only soft tissue. We have an important infection and an important bone resorption. So in this case, I decided to preserve the socket using the heterolog bone in order to maintain the volume and using the soft tissue graft in order to increase the volume and in order to protect the graphic material in the cavity. As you can see, this is the connective graft harvested from the palate. The thickness is about 2 millimeters. So I need to, after that, I need to remove the epithelium by the connective graft according to the Zucchelli protocol. Like this. Before the epithelium removal, using the blade, I can remove the epithelium exactly like this. And after that, I can use the suture, the resorbable suture, for the stabilization of this connected graft. Like this, in socket, exactly like this, using the resorbable suture. And after that, I used the resorbable membrane in the buccal bone and I fill the cavity with the heterolog bone. This is the CBCT reconstruction after the surgery. So this is the resorbable membrane and the bovine bone in the cavity. The occlusal view, and I used the Maryland bridge for the provisional rehabilitation. The healing 3 weeks later. So In other cases, we need to remove, for example, the impacted canine before the implant placement, exactly like this. For example, the patient has a double impacted canine in the maxilla, and a supranumerary tooth on the right side. So I need to remove this impacted canine before the implant placement. And this is the surgical phases. Using the piezosurgery approach, I removed both impacted canine and the supranumerary tooth on the right side, preserving the bone. And at this time, I didn't remove the premolar because the premolar is very important in order to guide the self-bone regeneration in this space-making defect. And this is the healing after the osseointegration of the implants, exactly like this. And this is the final restoration, the situation before and after. And it's very important to see the soft tissue shape before the treatment and after the treatment, after the self-bone regeneration, after the soft tissue management, and after implant placement. This is an amazing result in terms of the aesthetic results. The situation before and the situation after. With the X-ray post-op, before and after. So, in some cases, we need to use the GBR procedure in order to maintain the volume, using, for example, the reabsorbable membrane in order to protect the graft exactly like this in the space-making defect, as you can see from this histological result. So I need to cover the defect and to cover the grafting material using the membranes, reabsorbable membranes. In my practice, I use almost always the reabsorbable membrane, and the gold standard, obviously, in the GBR procedure is the autolog bone for the osteogenetic, osteoinductive, and osteoconductive characteristics. And when I need to have the necessity to cover the graft with the membrane, for example, in no space-making defect during the maxillary sinus procedure, in horizontal defect, obviously in the vertical defect procedure, I need to use the titanium membrane, not reabsorbable membrane. And during the treatment of the aesthetic zone, I need to have, before the treatment, in my mind, the final project. So I need to make the aesthetic analysis following the relationship between the lips and the teeth, the relationship between the lips and the teeth in smile position, in the rest position, the dynamic sleeps, the facial shape, the age of the patient, the function, and the aesthetic. For example, as you can see from this video, in my practice, I make always the pictures, intraoral and extraoral picture before the treatment, and a short video before and after, in order to have a sufficient documentation, clinical documentation, in order to make the best treatment for our patient in terms of the aesthetic and in terms of the function. Using, for example, the digital smile design, because with the digital smile design, I can have the possibility to have the virtual view about the final restoration, about the final treatment. And this is another thing very important in order also to increase the compliance by our patient. So don't forget these things: the use of the digital smile design, the use of the photos and the pictures before, during, and after our treatment. because using the photo and the video, I can see better and I can understand better the smile line of the patient, the tooth shape, the color of the tooth, the lips shape, and the phonetic and the relationship between the teeth and the lips. Because we can have different teeth shape, as you can see from this image, and also we need to follow the relationship between the length and the width of the tooth. We need to follow the tooth proportion in order to obtain a good aesthetic result. And also, we need to follow the relationship of dental midline to the facial midline. And for the aesthetic reason, this relationship should be within 4 millimeters in order to obtain a good aesthetic result. And also, we can have different smile shape: lowly pline, mediumly pline, and highly pline. Likely, in 69%, we have a mediumly pline because the highly pline is a very challenging case. And also, we need to check the relationship, the teeth exposure and the soft tissue exposure in rest position and in the smile position. Like this. The incisal line should be parallel respect to the lower lip in order to obtain a good aesthetic result. And now I will show one clinical case treated using this approach. This is the situation at the beginning. These are the extraoral photos, frontal view, lateral view, and intraoral photos. So I need to remove this old restoration in the maxilla. And as you can see from the OPG before, we have the edentulous site in the left side, we have a fracture on the central incisor, and we have the old restoration that I need to remove it. The periapical X-rays, the prosthetic face, in order to make the provisional rehabilitation, the color communication, and as I said before, I make the short video before the surgery, before the treatment, sorry, in order to understand better the relationship between the teeth and the lips, the teeth exposure, the soft tissue exposure, according to the face of the patient, the age of the patient. And as I said before, using the digital smile design, I can change and I can make the virtual plan exactly like this. This is the digital smile design procedure. I can and I need to increase the length of the central incisor using this virtual plan. From the virtual plan, I can obtain the works-up. This is the works-up. And by the works-up, I can make the mock-up. And this is the mock-up. And this is very important in order to understand better the smile line shape, the teeth proportion, the teeth dimension, and according with the patient, we can change these details. And after that, we can go ahead with the provisional treatment. So the situation before and after mock-up procedure. So now we can decide to go ahead if, according to the patient, the video before and after mock-up procedure, for the phonetic analysis and aesthetic analysis exactly like this. After that, I can make the provisional crowns, and after that, and only after that, I can start with the surgical procedure. Don't forget this protocol and this step-by-step procedure. So the surgical approach is the last step. And in this case, I placed 2 implants on the left side with the crystal center lift, as you can see, without immediate loading, the X-ray post-op. 1 implant in the right side without immediate loading. And after that, I removed the central incisor. This is the fraction, as you can see. And according to the protocol, I prepared 3 millimeter deeper in the apex part, exactly like this, using this palatal approach in order to place the implant at the same time, preserving the buccal bone and increasing the primary stability, because I need to make the immediate restoration. So following this protocol, I placed the implant, following this condition, using, as usual, the screwed crown, provisional crown, exactly like this. It's very important, the contour of this crown, in order to maintain the volume of soft tissue and also in order to obtain a good stabilization of the clothes during the coagulum during the healing. The X-ray post-op and the final view after provisional procedure. The situation before, the mock-up post-op, and the provisional rehabilitation after implant placements. After 4 months after the osseointegration, I can take the impression in the posterior side and I can make another provisional crowns on the implants. And this is the final restoration with the single crowns and veneers in the anterior side. Some details about the crowns, but it's very important to see the amazing result that I obtained 6 months later in the anterior side with a good shape of the soft tissue, and I prepared the crown for the veneers restoration, the occlusal view of the central incisor side with a good healing of the soft tissue, and the final screwed crown made in ceramic, the details of this screwed crown, and the final result. In this case, as you can see, I didn't use the heterolog bone in the buccal side, because in this case, we have more than 3 millimeters of thickness in the buccal side. And also we have less than 2 millimeters in terms of the gap between the implant and the buccal bone. So in this case, I didn't use the heterolog bone for these reasons, obtaining the same result, the same outstanding results. And this is the final view, single crown with a good aesthetic result on the central incisor. And the final view at the time of the crowns deliver. And this is my publication with my university in Milan about this treatment. And now I will show the last case, very challenging case regarding a very young patient. And as you can see from this image, we have an infection on the central incisor, as you can see from this picture. And this is the X-ray, the periapical X-ray, but it's very important to see the CBCT reconstruction to show the big lesion on the central incisor side. And it's possible to see better also in the CBCT reconstruction. So it's not possible to keep this central incisor. And for this reason, I decided to remove it using a full thickness flap, removing the lesion, performing the endodontic surgery on the lateral incisor, filling the cavity with the heterolog bone. And this is the healing, the X-ray post-op. But now I will show the short video about this surgery. This is the CBCT reconstruction to show the big defect that we have in this patient. The periapical lesion. So I performed the trapezoidal flap, full thickness flap with 2 vertical incisions. In this case, I used this flap, the full thickness flap, because absolutely I need to perform the endodontic surgery, the apicectomy on the lateral incisor, in order to keep it. This is the lesion after flaps disconnection. Using the piezosurgery approach, I performed the ostectomy in order to increase the visibility. Like this, I removed the lesion, and after that I can remove automatically the central incisor. This is a big lesion. After that, I removed the central incisor, and it's possible to see the root resorption caused by the lesion. And after that, using a dedicated insert, I prepared the apex of the lateral incisor, and I closed the apex with the MTA material like this. And after that, I used the bovine bone in order to overfill the cavity, because I need to maintain absolutely the volume in this aesthetic area. I overfilled the cavity also by the cavity, the socket, sorry, like this. And I covered the grafting material using the collagen membrane in order to protect the grafting material according to the protocol. This is the resorbable membrane. This membrane is more enough in order to cover this grafting material in order to obtain a good healing. And I used the interrupted sutures to close the flap, and I make the Maryland bridge. The situation after the surgery and the healing 6 months later. We have an incredible result in terms of the soft tissue healing and in terms of the bone healing. As you can see from the CBCT reconstruction, this is the situation 6 months later. After that, I can place the implant using a minimal invasive flap, the Brook flap design, and I prepared the cavity with the manual osteotome in order to preserve the bone and in order to increase the bone thickness during the implant placement, exactly like this, avoiding the traditional drills. And I placed this implant 3.8 of diameter and 13 of length. And this is the CBCT reconstruction with a good placement, preserving always the buccal bone. Without immediate loading. So I will wait 3 months, and after that I can take the impression for the provisional crown before and after for the final crown. In this case, I used the zirconia abutment and cemented the crown with a good result and a good soft tissue integration of this crown. And this is the follow-up 4 years later with a good result in terms of the long-term survival. So, at the end of this lecture, I would like to remember some things about this procedure. We need to perform always the minimal invasive extraction in order to preserve the bone. We need to place the implant according to the 3D placement. We need to place the implant in the post-extractive site below the bone at least 0.5 millimeter and 1 millimeter. I need to perform the tissue reconstruction using the connective graft from the palate. Is very important also to make a good provisional shape in order to maintain the volume and also for the coagulum stabilization. And I would like to suggest you the use of the screwed retained restoration, avoiding the cementum, because avoiding the cementum, I will have a less risk of the mucositis and the perimplantitis, and also using only one piece without 2 pieces, without abutment the crown, I will reduce the micro movements during the function. So thank you very much for your kind attention. And if you have any question, please feel free.
Hi, Angelo.
Hello.
Wonderful presentation, and thank you so much for the beautiful presentation. I would like to remind the viewers that they can ask the question into the thread, and we will get back to them very soon, answering their questions. And right now I have, another thing I would like to remind them that they can register onto this, the link given at the end of the thread, and they can get their C certification. So they can get their certificates from there by registering themselves through the link. And on behalf of my viewers, I have certain questions about the first case. Dr. Angelo.
Yeah.
Yeah, as per the first case, where you did the implant placement.
Yeah.
If we can have the photograph.
Yeah.
The first one. I remember, yeah, if you can see the central incisor over there.
Lateral incisor.
No, that's the missing one. The present with the crown.
The last case.
No, the first one, initially, which you showed, the first case.
The first case that I showed regarding the lateral incisor.
Yeah, that was a lateral incisor, missing lateral incisor.
Yeah.
I'm coming. Yeah, but if you see, there is this, here you can see this, the present central incisor, 2, with a crown. You can see there is a recession onto the crown.
Yeah, because I need, in the next step, I need to make the new crown on this central incisor. Absolutely.
Yeah, but
these are the old crowns by another colleague. So actually, after the lateral incisor restored, I need to change these old crowns with the new crowns, preparing the central incisor. Absolutely.
Yeah, no. My question was that if at the time of the surgery, suppose in somebody else clinic, a patient comes like this, and here you must have a referral case to you, and it was done by somebody else. So normally in your country, you don't touch those teeth. But suppose in case somebody comes in, do you advise that you do a soft tissue surgery to gain a good biotype onto that area, and you get a recession coverage also involved? You do a CTG or something onto that at the same time? Do you advise that?
Yes, absolutely. In some cases, I performed the connective tissue graft at the same time during the implant placement, but in this case, regarding the lateral incisors, I have, as you can see from this picture, I have a very thick tissue in terms of the keratinoids tissue. So in this case, I didn't use the soft tissue graft because I have a very important quantity of the keratinoids tissue. Is more enough. So we have less risk of the recession, and we have a very important thick tissue regarding the keratinoids tissue, the keratinoids gingiva on the central and the lateral incisor. For this reason, in this case, I didn't use the connective graft.
Okay. If you come on to the final picture of this case, with the restoration on the to the implant. Yeah, later, more. Yeah, here. So here you can see there are dark triangles. So do you have this consideration as per the Tarnoff's classification? Because if you can go on to the image, X-ray image, what was the crestal bone height over there in between the lateral and the central? Because
This,
there's both the sides, there's a dark triangle.
yes, but this triangle depends from this old restoration. So I need to
Yeah.
prepare this tooth, and I need to use a new crown. So
Mhm.
pushing on the soft tissue with the new crown, I will avoid this triangular back.
Okay. Okay. So at that time, your prosthesis onto the implant also needs some modification onto that time because your embracer, the contact point has to change to push and bring in the papilla because creating a papilla is a big trouble into the
I will change only the crown of the central incisor. I will not
Okay.
change the lateral incisor.
Okay. So
A particular case with a patient with some periodontal disease, but as we know, it's not possible to treat all mouth also for the economical reason. So I need
yeah.
to treat step by step. It's not easy and simple to treat altogether the dental elements, especially for the economical reason.
Okay. The second question about there was one case where you gave an incision, leaving the keratinized band, gave an incision onto in the mucogingival junction area.
Yeah.
One case, yeah. I think the last but one. Yeah, this one.
Yeah.
Here, so do you prefer giving incision exactly onto the mucogingival junction, or you come little bit, leave a band of keratinized tissue, so a millimeter below it?
Yes, I think it's better to perform the incision 1 millimeter below the mucosa gingia. So I,
So the closure is easier.
yeah.
Okay. And you do, I suppose you do some endodontic surgeries also.
Yeah.
So, so you prefer MTA or you prefer the latest material, which is um, uh, what do you? I just forgot the name, but that is the latest one where we it gets.
My
Um,
experience, yes, in my experience using the MTA, I had always a good result in terms of the healing. As you can see, from example, in this picture on the right,
mhm.
closure of the apex. So in my cases, I use always the MTA because I think it's also very easy in order to prepare.
Biodenti. I
Yeah.
was asking about biodenti.
Yeah, I never use it.
Okay, because biodentin sets very fast. Uh, MTA takes a little longer time to settle. I mean, setting time is little delayed into that. So that's why I asked. And another thing which I asked, third question, last one, is when you are doing in a compromised socket situation, doing an immediate placement after extraction. So you prefer doing the internal and external combination, or you plan it beforehand as per the thickness of the buccal bone, because that is very important. Because if it is less, it is known by the one of the publication by Vivian that if buccal bone is less than 2 millimeter, 1.5 millimeter, it has a tendency to create a dehiscence or a vertical bone loss of almost 7 millimeter. So I believe the viewers, they should always remember this thing, that they have to have a CBCT analysis before thinking of placement. I think that's very, very important. So do you prefer external and internal augmentation both, or you decide by, just like in this case, there's no buccal bone. The second radiograph, no buccal bone at all. So would you like to do a GBR procedure first, wait for 6 months and then go in, or you prefer placing the implant and doing it simultaneously?
In case, I prefer to fill the cavity with the heterolog bone in order to maintain volume, and after 5 months to place the implant. Because after 6 months, I have also the possibility to increase the soft tissue during the implant placement. So I think in extreme case, I think it's better to wait the integration of the grafting material, and after that, we can place the implant. I think is the best choice.
Thank you. And again, one more question, if you allow. Which biomaterial is your choice of biomaterial, which you prefer most?
Actually, I use the bovine bone by the B Innovation. This is the Brazilian company. I think it's an excellent grafting material, because after 5 months, in using this material, I need to wait at least 5 months. It's not possible to enter before 5 months, but after 5 months using this material, I will see that in the cavity we have a very hard tissue without particular chips, only hard tissue.
Okay, so you prefer mixing it with a autogenous bone?
Yes, when it's possible, yes. Yes,
Scraping?
when it's possible, yes.
Okay, okay. Yeah, because that makes the material a little more faster. The conversion is better after that.
Yeah.
So thank you so much, Dr. Angelo from Global Summit. And we are very happy to have you again here. And as I said, my viewers can get the C certification by registering themselves. And we are continuously coming down to you every weekend. And again, I would like, if somebody is interested, except dentistry, they can register for their podinars. They can register for their anything new which they have, the innovation or any product. They can register and they can nominate themselves for other fields. Dentistry is full for the coming year. So thank you so much being with us. Bye-bye. Good night.
Bye-bye. Good night.
Yeah. Thank you.
Thank you again.